Well, welcome everyone. It looks like we have quite a great cohort. So if the DNI Launchpad team gives me the thumbs up to start the introduction, I will go ahead. So welcome. Many of you know me, but I am Beth Burnside. I am a professor in the UW-Madison Department of Radiology, and I'm executive co-director for the Institute for Clinical and Translational Research. And I could not be more happy to kick off this inaugural seminar series. I'll tell you a little bit about the seminar series first, and then I'll introduce our esteemed speaker. So this seminar series is designed to be a monthly interactive seminar to learn about the four pillars of dissemination and implementation, implementation theory, implementation methods, implementation strategies, and implementation laboratories. Each seminar is held on the second Friday of every month between noon and 1 Central Time during the 2025-2026 academic year. It's open to all and in part of the Implementation Science and Community Health Outcomes or ISHO certificate, which addresses the gap between basic research discoveries and their application in clinical and public health practice. And you'll notice I gave Central Time because I think we have people who participate from across the country and even outside of the US. So it is really my distinct honor and great pleasure to introduce, for those who have not yet met her, I hope many of you have met her, Dr. Shelley Ellis. She is our new, since May 1st, director of the UW Institute for Clinical and Translational Science Dissemination and Implementation Launchpad. Dr. Ellis is a health services researcher and implementation scientist who has built her career on a simple yet profound idea. A brilliant medical breakthrough is only truly successful when it can be used to help people in their own communities. For more than 2 decades, she's been the bridge between groundbreaking science and the doctors and patients who need it most. She is a lifelong learner. It's so fun to talk to Shelley. She's always learning something, asking curious questions. And a leader. She's an alum of the Mentored Training in Dissemination and Implementation in Cancer Research, or the MT DIRC program, and an associate editor of Implementation Science Communications. Her work as an implementation scientist focused on the crucial question of how. How can we ensure that things like clinical trials, prostate cancer screenings, and the latest genomic tests actually make it into the community clinics? This passion led her to lead the National Institute for General Medical Sciences, or NIGMS, funded Precision Community Study, and develop Team Sport, a powerful team-based intervention that helps doctors bring targeted cancer treatments to their patients. Dr. Ellis's dedication extends especially to rural communities where she has tirelessly worked to improve access and care and increase participation in clinical research. This deep commitment led to her being named a visiting scholar at the NCI in 2019. Dr. Ellis's faculty appointment makes sense, in the Hematology and Oncology and Palliative Care department here at UW under the Department of Medicine. Through that affiliation, her ICTR affiliation and leadership role, for her cancer center work, and in collaboration with many, many other teams, I have so much confidence that Dr. Ellis will continue to inspire and empower us all to ensure that no community is left behind in the pursuit of better health. So Shelley, we're so excited you have joined us at UW. I'm going to turn it over in 1 second after I do some housekeeping. So if you have a question or comment, please put it in the chat. Our fearless DNI Launchpad team will be monitoring the chat. And then after the discussion and presentation, Molly Murphy will be moderating some of those questions to help Dr. Ellis navigate them. And I just really do want to thank the entire DNI Launchpad team. This is a team effort, as Shelley always says. So thanks to all. So with that, Shelley, I will turn it over to you.
Thank you so much, Beth. That was a fantastic introduction. I really appreciate it. And I am just so excited to be here. And I'm very happy to be at UW and amazed at all the wonderful work that I keep seeing and learning about. And very excited to forge a new path with all of you joining us to continue to think about dissemination and implementation and all the opportunities we have to use it and to help us build great programs to make that happen. So Kathy has put a question in the chat, and I hope you can answer it. We'd love to get a gauge of where you see your skill level in implementation science. Um, so as you're submitting your answers, I would love to see if Kathy, if you can show us where folks are.
I'm just going to leave it up for another 30 seconds or so because it looks like a couple more people have logged onto the meeting. And then I will show
Awesome.
the
Thank you.
results.
Awesome. I think the important thing is that no matter where you are on this spectrum, I think we can all keep learning. I was reading some materials that one of my colleagues shared last night as I was preparing for this, and I was like, I have never seen this resource before. It's amazing, and I was learning all kinds of new things. So I think it's safe to say that D&I is a new field, and that we're all still learning about D&I. Okay. So about half of you are feeling like you're at the beginner level, maybe being a little bit modest. We've got a good proportion of intermediate learners and some advanced and expert learners too. So that's great to know. And I am excited to try to meet all of you where you are. I think in this seminar series, we'll try to offer something for everyone, but we'll keep in conversation so that we make sure that we're hitting all of those areas. So let me move on. So today's goal is really to introduce you to the implementation seminar series, which Beth has already laid the groundwork for, provide an introduction to dissemination and implementation science, and also connect you with the D&I Launchpad. If you really are a beginner, maybe you don't know about the great services that are here at UW that can help you with your work. So we're going to speed through this, so let's go. So, as Beth mentioned, the seminar series we're really excited about it for this year. This is a long-standing thing that the ICTR has offered, but we do have some really great people coming in from outside of our university, some really thoughtful, knowledgeable folks in the field of dissemination and implementation. We have Ann Sales, who I call the godmother of implementation science. Um, a nationally notable economist, Ramsey Saloom from the University of Florida. We have uh, Sarah Birkin, who is incredibly thoughtful, impactful implementation scientist who's going to come and talk about theory later on. They're complemented by a lot of amazing, great work that's happening here at UW. And so we have a lot of things that we're going to cover this year. If you'd like credit for this course, there is an option to get credit, and I want to welcome the students who are already committed to earning credit for the course. So if you have any interest in doing that, you can contact me and I'll get you hooked up to be able to do that. The other thing is that this course and the credits earned are also applicable to the implementation science certificate run by Barb King in the School of Nursing. And so if you're interested in that, you can get the link or go to the ICTR website and find out what that all entails. So just interested if folks are interested in any of these opportunities. So Kathy, can you share those results? Okay, so excellent. So I'm excited to see that there are some learners who are interested in gaining credit, and that's very helpful for us to know as we plan going forward. So thank you, Kathy. So enough about the course. Let's start talking about dissemination and implementation science. Um, I'm going to give you an overview of the field. I'm going to introduce these key concepts and the pillars that Beth mentioned. And really, just we're not going to be able to cover everything today. And I don't think you're going to walk away feeling like you've learned as much as you can about implementation science. But I hope I offer an opportunity to um, point you to the direction of when to come back in the seminar series to learn more about different things. So implementation science, as I mentioned, it's still a brand new field. This is a PubMed search of the words implementation science, and it first started showing up in the literature only in 1993. So we're just still, figuring out what dissemination and implementation science mean. And as you can see, there's been a lot of growth, but we still have a long way to go. And I invite you to help us shape this field because there's still a lot of opportunity that you can do that and you can get involved in making things happen. I won't go through the entire evolution of dissemination and implementation science, but I think it showed up in the PubMed literature in 1993, but a lot of important things were happening before that. Everett Rogers published his book in, I think, 1961 about diffusion of innovations. And so he's really thinking about how innovation spreads, particularly in the agricultural communities. But other things were happening too that helped solidify the field of implementation science. So also in the 60s, healthcare providers started getting together and thinking about practice-based research and forming practice-based research networks so that they could study what they do and better understand how to provide good care. In 1995, really there was a solidification of evidence-based medicine, which is pivotal to implementation science. So really understanding what is effective care. You have to understand what's effective and before you can actually implement things. You got to know what to implement. So that was really important. In the early 2000s, community-based practice participatory research, that methodology came into play and really understanding how to engage patients, also community members and others who were interest holders in the care that we provided. And that was really important to help shape the methodology of what we're doing. The field continues to evolve, and we recognize that there are other things that we need to incorporate into implementation science, and that work is evolving. This is my perspective, my lens is healthcare, but it's evolving across other fields too. So in the field of education, we're borrowing methods there. They're doing this kind of work in that discipline as well, and others. So it's not just limited to healthcare. So I say that and sort of think about all the sort of milestones that happen to make dissemination and implementation sort of congeal as a field, but recognize that implementation science is really built on a foundation of a lot of other behavioral and social sciences. And what the foundation, the theoretical frameworks of implementation science do is they have compiled all the best knowledge from sociology, from psychology, from health services research to really think about, particularly for in healthcare, what makes people change their behavior, and have tried to bring those all together in a consolidated, comprehensive way. And so I don't want you to get mad at me if you're like struggling with theories and frameworks, for example, and then realize that, oh, yeah, this is just, what somebody else has already learned. We're taking the best from a bunch of different fields and putting it all together to help make change as efficiently as we can. The other thing I want to say is that dissemination and implementation is really a big tent. There's a lot under the umbrella that we talk about with dissemination and implementation, and there are different ways to approach the work that we do. And so I think about it sort of from two ends of the spectrum. So there are people who are innovation developers, and they create innovations, and they want to make sure that they can disseminate those and bring those to scale. And they take an approach that might start with, developing the innovation, and then as they develop it, thinking about who's going to use it, what's the end goal of this innovation that they're developing, and really developing it with those folks in mind. We call that design for dissemination. There's another group of people that start maybe from another end. So they look at what exists already in terms of healthcare or other kinds of evidence-based practice. And they think about the gaps in quality that exist. So really looking at where people are missing out on getting the care that they should get, or other evidence-based practices that they should get. And so they start from that gap and think about what is getting in the way of people providing evidence-based care. They do assessments of the determinants of those behaviors, and then think about strategies that could help folks bridge that gap, and then test those strategies to see if what they're doing actually works. So there are really a lot of people coming at this from different angles, and bringing in different disciplinary perspectives. And we like to include them all in what we do and learn from the best of what's out there. Certainly in the 30 years, D&I is now really solidified into a field of science. We have our own journals, and they're very robust. Here's just a couple of journals that really focus on implementation science, but there are many others, and many clinical journals that have implementation science sections, and make sure that they include that in what they do. I think implementation science is recognized and respected, and the need for it is understood by many funders now. There's a special NIH study section. There are most institutes and centers at NIH, for example, are funding dissemination and implementation research of some kind. And there are many training opportunities for learning more about this and applying these tools to clinical and other problems. I think we see that it's becoming institutionalized. It's now a required part of groups like ICTR. We call them CTSAs. This is major infrastructure for academic medical centers. And there are many groups like ICTR across the country see implementation science as a core feature of what they do, and now we're actually required to offer these kinds of activities. When I started out, we just talked about translational science as T1 and T2, so translating from bench to bedside, and then bedside to actual patient groups. But now we think about a larger translational structure and more phases of that, and are a little bit more particular in how we do that. But implementation science certainly fits into the translational science spectrum. So why all the fuss? Why create this whole new field of study? Well, a healthcare intervention that is 100% efficacious. If you can imagine a pill that treats everyone who takes it and cures them from their disease, that would be wonderful. But if no one ever uses it, then it's 0% effective. So you have to not only create the evidence-based practice, the innovation that can help people alleviate their suffering, but you also have to get it into the hands of the people who need it. And in healthcare, that's mediated by the healthcare providers. In other settings, there may be teachers involved. There may be others who, mental health providers, others who actually have to deliver that. So we have to work with the delivery systems that exist to make sure that people actually get the innovations that they need. And there's a lot of description in the implementation science literature about the evidence to practice gap. And it's often said that it takes 17 years for an innovation to actually make it into practice. People talk about the fact that only, there are all these leaks in the pipeline. Only about 14% of evidence actually reaches patients. And when we ask people who are decision makers if they ever go and look at for evidence to figure out what to do in their practice setting, only 18% of them say that they actually look for evidence when they're thinking about how to do their practice. So that's the evidence to practice gap. And this is not a new problem. This guy, Ignaz Semmelweis, he noticed a really important difference in maternal mortality back in 1840. And he actually came up with the answer to fix this problem. He realized that doctors weren't washing their hands when they were going from autopsies back to helping women deliver babies. And so he insisted that people wash their hands, and childbed fever fell drastically. But he never was really able to spread that innovation. It wasn't until the 1980s, almost 150 years after he discovered this, that hand hygiene guidelines were published in the US. And he had a lot to learn about how to get people to change their behavior. And so that's a problem that we are working on as we're thinking about how to fix the evidence to practice gap. I see this in my own work all the time, and it's just about in every corner of clinical care that I work in. We see that none of the innovations are really adopted rapidly, and there are these huge gaps where oftentimes it's no better than chance whether people are going to get the evidence-based practice that they actually are eligible for. So we have a lot of work to do, and we're glad that as many people are here today and interested in implementation science, because we need your help in delivering these. So I want you to just, we've spent a minute talking about evidence-based practice, and I just want you to put in your mind, what are the evidence-based innovations that you are interested in spreading or making sure happen? And thank you, Kathy, for sharing those with us.
We have a couple more people responding.
All right. I can see that 100% of you have something, but I can't see what your evidence-based practices are. I'm glad that you all have something in mind, and that hopefully we'll get to talk more about what those are.
I have the results on a
Okay.
different screen if you'd like to know a couple of
Yeah,
them.
sure.
A couple of them are mental health screening and treatment, clinician education programs, a personalized portal for decreasing environmental exposures.
Awesome. So it sounds like we have very varied interests, and I like that not all of the things you're interested in are healthcare related. And so I hope throughout this series that you help hold me accountable to talking more about things that aren't just healthcare related. Awesome. So I just want to stop and pause and think about what we really mean and what are some important like definitions for us as we sort of get on the same page coming from different disciplines. And I also want to point out this great resource that my colleague Molly Murphy suggested and offered for this class, which is an amazing glossary of all kinds of terms thrown around in the field of dissemination and implementation science. And this is where I learned new things last night, scrolling through these. But I think this is a tremendous resource, and I encourage you guys to pick it up and look at it. But, really in dissemination and implementation, we really talk about an evidence-based intervention, something with proven efficacy and effectiveness. And this is what we're really trying to disseminate and implement. And often in the field, you might get, if you submit a paper or submit a grant, people really want to know that the thing you are implementing or disseminating is evidence-based. There's really a sort of a ethical and moral thought that, or imperative that you really shouldn't be implementing something that isn't evidence-based. I'm not sure that that's the final answer. And I think we can think about and learn about dissemination and implementation. Even there are many things that are not evidence-based that are disseminated and implemented rapidly. And I think we can learn a lot from that. But it's something that we as a field think about a lot. And we'll ask you to ponder what is the evidence base that you have for what you're implementing, and is it appropriate time to think about implementing something? And then on the other side, thinking about if it's no longer evidence-based, or if you study something and you find out it's not evidence-based in the process, what are your plans for de-implementing something, which is another thing that we talk about a lot in the field. So dissemination is really thinking about how you spread these evidence-based interventions to the target audience, and thinking about determined channels and using planned active strategies to make that happen. Implementation is the process of putting into use or integrating evidence-based interventions within a setting. And as I mentioned, de-implementation is just important, thinking about reducing or eliminating inappropriate, ineffective, or potentially harmful services or public health programs. And then in the context of translation, which is sort of a larger idea, how do you move research findings from one translational phase to another across the translational science spectrum, with the goal of intending to speed the translation of discovery into practice? The other thing I like to talk about, and this I borrow from Ann Sales, as I mentioned, who I mentioned earlier, and is coming to talk with us. But thinking about what is D&I science in particular. So if implementation is the process of planned human behavior change under organizational constraints. So just thinking about how do you make change in an organization typically. Implementation practice is the process of supporting that work of human behavior change under organizational constraints. And then when we think about implementation science, it's really the study of how you do this better. And so there are many opportunities to support implementation practice and to support implementation science, but sometimes it's helpful to just think about the difference between those two, and what your goal is in the whatever work you're trying to accomplish. Okay, so I want to introduce what I call the 4 pillars of dissemination and implementation science. I'm not sure that there are only 4 pillars, but these are things that I like to think about. So theory, methods, strategies, and laboratories. I think these are key components that help us do our work and are all necessary. And we have a lot of work to do in each of these areas. So why theory? This is really intimidating for a lot of people. And some people like to just jump right to doing the empirical work. But in my estimation, I think theory is really essential to create generalizable knowledge about how to implement things effectively. I want to know what works and what doesn't. And I want to know as much as I can about which tools to select when I'm recommending something for others. And so I think theory can help us know the real reason that evidence is not taken up to match. And the purpose of that is we want to match the reason why we're not getting the result we want with the thing that is actually going to affect that reason. So a simple answer, and maybe our educational colleagues might agree or take umbrage at this, but A lot of times we just jump to, oh, people just don't know what to do. So we just need to educate people. They don't know what the right thing is to do, or they don't know the evidence-based practice. And that's not always the case. A lot of times we find that education is part of the answer, but it's not the whole answer. There might be complete systems or organizational barriers that are in the way. And so just knowing what to do is not really always the most effective. And there's some evidence to back this up, and we've looked at different implementation strategies, including continuing education, for example. So we need to really understand what underlies the reason that people are not doing the desired behavior that we want them to do, and match that with the kind of thing that will actually fix it. So if we always just match training with an implementation gap, evidence-based practice gap, we might not always be able to address or change what we want to change. I think it's really important to think about specifying what it is that we are doing, and then testing and finding out if that actually works. As we go through the series, we're going to address more and talk more about theory, models, and frameworks. But one of the things, just a heads up, and if you're brand new to implementation science, people can get really overwhelmed. There are lots of theories, models, and frameworks out there. And there are different kinds of theories, models, and frameworks. I think this is a helpful way to think about it. There are theories that really help you through the process of the steps of what you might need to do to implement something. And then there are other theories that are the kind of theories that tell you why change isn't happening or might be able to happen, or why different implementation strategies might work. And so there are different kinds of theories, and then there are evaluation frameworks. And those kinds of theories help us understand what we should measure and how we should assess the work that we do. All of these are very important. It's possible you might be writing a grant and need each 3 different types of theories to guide the work that you're doing. That's not unheard of, but as we get through the semester, we'll learn more about these and help you to understand the differences between these. Here's just a tool that you can go online to help you use dissemination and implementation models in health in particular. And so this might be something that you wanted to look at to sort of start to figure out what theory or model or framework you might want to use. I think this is an opportunity to say that we have not probably done enough work to build theory and test theory in implementation science, and it's something that we actually need in the field to grow the field and make our recommendations for people who want to apply our tools better. So that's something that I invite you to think about and join us in doing. And then in particular, thinking about the theories and science around de-adoption and de-implementation as an area that we certainly need work in. So those are just 2 areas that you might think about expanding what you do. But come back on October 10th, where Sarah Birkin will talk to us and help demystify this a little bit more. So the second pillar I want to talk about are methods. And oftentimes, when we think about implementation science, a lot of times people really think about qualitative methods. So that work that if you're coming from quality improvement and you're used to thinking about root cause analysis, this is where we apply theory and methods to really determine why behavior change or the ideal behavior is not happening. And so we use some very rich qualitative methodology to think through that. Or if we're thinking about designing for dissemination, we might use very rich qualitative methods to understand the users and how they would use the innovation that we're developing. So qualitative methods are incredibly important in dissemination and implementation, but that's not the only methodology that's important. And so all the methods are really under the umbrella of dissemination and implementation research. We certainly need patterns of care study. We really need to understand what the practice gaps are. So we have to be able to measure that. So, some quantitative skills that can help us measure care delivery are very important, or standards of care in other non-healthcare settings. We do a lot of work to understand the workforce and who's available to help us deliver the things that we want to deliver to our ultimate patients or students or whomever we're working with. So those kind of quantitative methods are very helpful. But also, we do a lot of work once we are at the point where we've got implementation strategies and we need to test those implementation strategies. So we really need experimental designs and quasi-experimental designs that can help us test that. And there are numerous opportunities to learn about those methods and to advance those methods, because the kinds of ways that we are working in real world settings and across large swaths of schools or clinics or health systems really take some, sophisticated methods. And not only do we want to be able to test those implementation strategies, we also want to optimize those strategies. And we know that maybe more than one strategy is necessary. And so we need to really speed up our ability to do that. And so looking at sophisticated methods that can help us do that is really important. This is just sort of like if you're thinking about the various steps that you might approach an implementation problem, it sort of shows you where the different kinds of methodologies might come in handy. So we prove there's an effective practice. Over here, probably using clinical trials or other experimental methods to do that. We use some more quantitative methods to understand the research to practice gap. And then we might use very rich qualitative methods in the middle to really think about what are the determinants of adopting the evidence-based practice, and how do we figure out with that gap, what are the strategies that people would actually find feasible and acceptable to use. And then once we think we have the answer, we might go back to some more quantitative methods and experimental or quasi-experimental study designs to really actually test that. It's also notable to think about, we have implementation outcomes that might be different from the regular outcomes that we would use in understanding the effectiveness of an intervention to begin with. So again, join us. There's plenty of room to develop the methodology. We need reliable, valid, pragmatic measures of implementation constructs. We need lots of help in understanding and evaluating the costs of these implementation strategies and the benefits and the ratios of that to the people who bear the cost of these implementation strategies. And we need to further develop how to scale up and spread implementation or evidence-based practice. So lots of room for you to help us. And as a result of the need and what we hear from other folks, we have a couple of times that throughout the semester that we're going to really focus on methods. So come back and hear about methods they use in other fields like commercialization and human factors engineering. That will be a part of what we're doing, but we'll also talk about economic analysis and implementation research and pragmatic clinical trials throughout this series. So talking about moving to a third pillar, implementation strategies are really important. And what are implementation strategies? So those are the methods or techniques used to enhance the adoption, implementation, and sustainability of a clinical program or practice. It's the stuff we do. So if anybody was here earlier this week and attended ICTR's Research Day, you saw Jeff Curran, who came up with this really important and very simplistic way to think about implementation science. So the intervention, the practice, the innovation is the thing. Effectiveness research looks at whether the thing actually works. Implementation research looks at how best to help people and places do that thing. And implementation strategies are the stuff we do to try to help the people and places do the thing. And then we can measure implementation outcomes by how much and how well people do the thing. And so really the implementation strategies are really the things that we do to bridge the evidence to practice gap. And I think that might be helpful for folks to think about. One of the important things and part of implementation strategy mapping, like how you get from those determinants of, those barriers that are getting in the way of people doing the behavior, and the implementation strategies to fix the problem, is really defining the, processes of implementation strategy mapping are defining the problem in behavioral terms, really selecting what the target behavior should be, and being very specific about what that entails, so that you can really determine what's getting in the way of that behavior. We'll talk more about implementation strategy mapping when we talk about theory and when we talk about implementation strategies themselves. Again, area where we have plenty of room to grow, to understand implementation strategies better, what works when and in what context. And you can help us better operationalize and test the sustainability of these strategies. We'll come back in January and again in March, and we have experts coming in to talk about two different groups of implementation strategies: audit and feedback, which is widely used and probably the most studied implementation strategy. And then folks here in the School of Pharmacy who can help us think about different kinds of facilitation, coaching, and when we send a person in to help people fix their evidence to practice gap. Okay, so the fourth pillar I want to talk about is where we do this work. And I think this is probably certainly the area where we have the most room to grow. But as we think about, 30 years in the field of implementation science and our need to really move to understanding which implementation strategies work, optimizing those strategies so that we're recommending the best way for people to do that, we really need to think about where we work. Perhaps in some fields this might not be as important. And I'm thinking of, in schools or thinking about student strategies. You have an infrastructure where you have students organized into classrooms and schools and school districts, and that infrastructure exists in a very structured way. And we can maybe debate about this if that's how that works. But in healthcare, our system is not really a system, so it's harder to have organized structures where we can study healthcare. And so thinking about the places where we test the implementation strategies that we're interested in, I call these implementation laboratories. And there are some implementation laboratories that already exist. We have learning health systems, and they're very structured for thinking about continuous improvement and innovation and having infrastructure where you can actually pose research questions. The caveat is these are typically in academic centers and often sometimes focus on inpatient care. That's changing over time, but that's traditionally been the model. There are also practice-based research networks, which are groups of primary care clinicians and practices working together to answer questions that they find important or discover in their inability or abilities to deliver care. And those are typically in ambulatory care settings. But as they're organized, they have some infrastructure that helps them be set up to do work. They typically have a common data infrastructure. They have some governance that brings them together to help them decide what research questions to ask. They have people who are often helping them introduce innovations in those systems and are certainly set up to ask questions. And so those are important features that help us study the things we want to do. But there are often times that those aren't the settings that we want to work in. And so we need to think about other settings, maybe mental health care, maybe community organizations. And so we need implementation laboratories in all of these different kinds of contexts to be able to answer the questions we want to answer. Many of the things that we'd like to know that might help us better do this work are thinking about collecting other data on the units that are in these networks. In healthcare, some of the questions might be about the providers and the pay structure of how these units operate. But we can also ask other questions about the organizational climate or find potential champions who can help us with future implementation questions. So again, lots of room to grow in this area, and we'll think about this as the semester goes on. We have 2 opportunities in December and May to learn about these different kinds of implementation laboratories and perhaps think about others as well. The other thing we're going to cover in this series is intersections of different kinds of fields of study. So where does quality improvement intersect with implementation science? Where does human factors engineering intersect with implementation science? But there are other fields of study that we can think about, health communications, is that dissemination? What about marketing? What about commercialization? Like, aren't we doing the same kinds of activities? And are there tools in those fields that we could borrow or use to do our work? And so we'll revisit this certainly in November and again at the end of the semester. But we'll continue to think about these questions even beyond the seminar series. So just a word about the D&I Launchpad. If you don't know about it, please come and visit us. We exist to help move evidence into practice, help people expand the reach of their innovations and accelerate adoption. We offer free one-on-one consultations. We have several scientists who help us and are available to you to talk through these issues. There's pilot funding offered by ICTR that supports dissemination and implementation work. So that call for proposals just came out yesterday or earlier this week. So feel free to take a look at that. We also want to bring together this scientific network. So we'll be offering you other opportunities to get together as we move on. And then we also have lots of tools and resources on our website. So please take advantage of those opportunities. And if you need help, ask us because that's what we're here for. I just want to say we're expanding or thinking about how to do more things in the future. And so if you think about other things that you need, we would love for you to participate in our ongoing, we have right now open a survey, a D&I needs assessment. So if you don't know about that, if you haven't gotten an email about that, please connect with us and we would love to hear from you about what you need to support your work. So we're thinking about many things that we could possibly do, and it looks like you want us to do them all. But I think these are some of the things that in the future we might be able to offer you, helping you solve research bottlenecks, connect with other people in the community who are the implementation laboratories that you need, connect with mentors, or just coming up with groups that can help solve the challenges that you're working on. So thank you for participating and giving us that feedback. And I'm going to turn off my slides and open it up and turn it over to Molly.
Thank you so much, Shelley. This was absolutely great as an introduction. We're seeing that via these, clapping, whatever, Zoom hands. everyone, please feel free to submit via chat or at any time uh, to us at the Launchpad your questions or comments or interests for future um, seminar presentations. We're very hopeful that we're able to be responsive to the needs and interests of all of you. To that end, one of the people pursuing the iShow certificate had submitted a question. Um, I think it came from Emily, and Emily, if you want to rephrase, but I'll try to summarize to get the discussion going. But I think it was a question about um, how can implementation science, or what's the level of like flexibility within implementation science frameworks to be able to respond to the kind of rapid shifts in terms of like what patients' needs or interests are.
Mm.
Emily was speaking, I think, particularly from a palliative care. Um, Emily, go ahead.
Yeah, Dr. Ellis, I was just looking at your background, and from meeting last night, I just was thinking about discussion questions, and I last minute realized I did not do that, so I quickly emailed you. But yeah, I'm very new at this, and I just like to know the flexibility of things and what we need to be thinking about, especially with populations and in healthcare that do shift rapidly, like palliative care, people in dementia, people with neurocognitive disorders. There's a whole slew of things that I could say.
Yeah, I mean, I think I face this myself in this precision oncology space where the evidence is changing incredibly rapidly. And so what we appreciate is like it's very hard for us in a research study setting to keep up with the weekly evidence changes. And I can only imagine for healthcare providers, they are also struggling with those, the tsunami of evidence changes and trying to keep those, keep up to date with those. And so, part of what we're trying to implement is a flexible system that can help them keep up to date. So, we are recognizing that the field is changing rapidly. And so, what tools can we put in the hands of those healthcare providers that is flexible enough to change at the pace that needs to change and keep incorporating things as they come online? So, it might be some kind of digital decision support kind of thing, or just a resource that we have to figure out how to keep up to date. But that's certainly an issue that we're facing, and I look forward to talking to people and, how are we solving this problem? Are there informatics tools that we can use to do that? When even, the people who are creating the guidelines are, struggling to keep up as well with the pace of change. So that's a great question, and let's explore it this semester.
And very apropos, I think it's a very implementation science oriented question, and that it's how do we be adaptive? How do we be pragmatic and adaptive?
Thank you. I tried.
You did a great job. um, yeah, anybody please put in the chat or feel free to raise a virtual hand to ask another question. Otherwise, I'll proceed with another question from um, a student pursuing the iShow certificate who asks a great question. What's the difference between implementation science and translational research?
Yeah,
Or
I think
is there
that's a
one?
great, yeah, I think I took a slide out, but I because I thought it was too healthcare focused, but I really think about um, health services research is a big bucket, but I think, people coming from different disciplines might like orient their buckets, their field as the primary bucket and then sort of nest things underneath it. So I think of implementation science as part of health services research. But in thinking about the translational science spectrum and translational research, I think I showed the slide of the T1, T2, T3, T4 sort of spectrum. So I feel like implementation science is right there at the end of that, T3 um, uh, part of it. So implementation science is really doing that translational work. In fact, like thinking about the first implementation science kind of grant I ever worked on, it was this under this in NHLBI group of studies called Translation of Research into Practice. So that was really seen as that step where you're taking what we've learned in a clinical trial and moving it out to actual clinicians, either in your institution or in lots of community institutions. And so it's really implementation science is that part of the translational science spectrum.
And just to be totally clear for everybody in this first of our many wonderful seminars, can you explain T3 for folks?
Yeah, I think maybe we should put that slide back up, but I think T3 is really the part. So T1 is thinking about like you have some really basic science discovery and you're thinking about how that might, be moved to a therapy or, something you could actually do to help patients. And then I guess T2 is bench to bedside, and then like how you actually use it in a human setting. And then T3 is really how do you take something that you know works and then translate it into a national guideline. Like how do you make a recommendation? What do you tell people to actually do to prescribe this, to make it happen in a clinical setting? And it doesn't have to be a clinical setting, but whatever that evidence-based practice is, how do you figure out how you actually use it and
Yep.
then do it to scale.
Yep. Great description. We're at 1 minute left. I'm happy to stay on if others have more questions, but thank you so much, Dr. Ellis, for your presentation and for welcoming us all into what will be a really rich seminar series throughout this whole year. Everyone, please feel free to give us feedback via email, but definitely please respond to our evaluation or our feedback survey that I think Kathy put the link in the chat. And you'll also receive an email about that. But welcome, everyone. We're very excited for this year. And yeah, we hope that this will continue to be a great opportunity for us to learn with and from each other. So please let us know what you're interested in, what questions you have. And yeah.
Great. Thank you very much. Look forward to it.